Hi everyone, welcome to the screencast for week 3 of the 2017 Respiratory Core. This week's questions and lecture are about lung perfusion and ventilation, and for this screencast I will focus on hypoxic pulmonary vasoconstriction. Here are some of the Royal College knowledge requirements regarding the pulmonary circulation. I think that reviewing hypoxic pulmonary vasoconstriction, or HPV, will be useful because it requires a good general understanding of the other topics listed here. So, to get right to it, what is hypoxic pulmonary vasoconstriction? It is a physiologic mechanism in which the pulmonary circulation constricts in the presence of alveolar hypoxia. The purpose of this mechanism is to improve VQ matching. In this diagram, you can see that one of the alveoli has decreased ventilation, perhaps due to infection. In this case, ventilation is reduced, but the flow is similar to that of the well-ventilated alveoli. As a result, there's increased shunt fraction and a reduction in the overall arterial partial pressure of oxygen, or PO2. When hypoxic pulmonary vasoconstriction kicks in, the vasoconstriction at the site of alveolar hypoxia reduces the flow through that non-ventilated area and diverts more flow to the ventilated area. This results in better VQ matching and therefore improved arterial oxygenation. This diagram demonstrates the typical pattern of HPV. As you can see, the HPV response is biphasic. The first rapid phase begins within seconds of hypoxia and peaks around 15 to 20 minutes. This is then followed by a late response, which results in maximal vasoconstriction at the site of hypoxia over a 2 to 4 hour period. The HPV response is further enhanced if there's some period of pre-existing hypoxia. As you can see towards the right side of this diagram, it takes time for the pulmonary vascular resistance to return to baseline after normal alveolar PO2 has been reached again. There is some controversy about the exact mechanism and site of action of HPV. Various mechanisms for the vasoconstriction have been proposed, including calcium-dependent vasoconstriction. The important thing to know is that the primary stimulus for HPV is the alveolar partial pressure of oxygen. This makes sense because this will lead to detection of regional hypoxia and therefore cause regional vasoconstriction. The pulmonary venous PO2 also acts as a stimulus for HPV, but to a smaller extent. The alveolar PO2 is effective as a stimulus in the physiologic range of 40 to 100 millimeters mercury. It is also most effective when 30 to 70% of the lung is hypoxic. Less than 30% may be an insufficient stimulus for HPV, while greater than 70% hypoxia may lead to generalized vasoconstriction. HPV can reduce a shunt fraction by about 40 to 50%. There are some important factors that affect HPV. Hypercapnia will increase pulmonary vasoconstriction, and so will respiratory metabolic acidosis. However, acidosis is expected to produce generalized pulmonary vasoconstriction rather than having regional effects. In contrast, respiratory metabolic alkalosis cause generalized pulmonary vasodilation and are therefore detrimental to HPV. Similarly, hypothermia attenuates HPV. Cardiac output and mixed venous oxygenation are a bit more complicated. In a healthy anesthetized patient whose metabolic requirements remain stable, a low cardiac output will result in a lower shunt fraction, which is good and indicated in the graph by QS over QT. This would theoretically improve HPV, but the low cardiac output also leads to a lower mixed venous saturation and therefore reduces arterial PO2. Raising the cardiac output to supranormal levels increases the mixed venous oxygen saturation, which attenuates HPV, and it also increases the shunt fraction. Therefore, it is important to maintain normal cardiac output. There are also anesthetic and surgical factors that affect HPV. Surgical manipulation of the isolated lung in thoracic surgery can reduce the blood flow to that lung, thereby reducing the shunt fraction even further. However, manipulation of the lung tissue can also release inflammatory substances which actually attenuate HPV. Halothane, enflurane, and isoflurane have been shown to attenuate HPV due to pulmonary vasodilation at and even below 1 Mach, especially halothane. The effect of newer volatile anesthetics is unclear, but likely is insignificant at 1 Mach. Nitrous oxide increases pulmonary artery pressures and likely inhibits HPV, according to Miller, although this evidence is from animal studies. IV anesthetics have not been shown to impact HPV, and the same goes for regional techniques if cardiac output remains stable. Inhaled nitric oxide, which is used in pulmonary hypertension, is beneficial as it selectively vasodilates pulmonary circulation in ventilated areas of the lung. In contrast, direct vasodilators cause generalized pulmonary vasodilation and therefore attenuate HPV. HPV is important in our clinical practice. This is most obvious during lung isolation in thoracic anesthesia, where HPV becomes critical in diverting pulmonary circulation towards a dependent, ventilated lung. However, it is also important in maintaining adequate oxygenation and effective ventilation in other scenarios, such as atelectasis and in severe COPD. For example, a patient with severe COPD relies on HPV to maintain adequate VQ matching. Giving a patient like this excessively high supplemental oxygen can actually lead to a decrease in HPV and higher shunt fraction. It would also divert blood flow from well-ventilated units and thereby worsen dead space ventilation. I hope that you found this brief review of HPV to be useful. Thanks for listening, and here's my dog Oreo.